Hello, everyone. My name is Dr. Richard Horowitz. I am the co-host of the Doctor Talk Healing Lyme Summit 2.0. It is my great pleasure to introduce a longtime friend and colleague, wonderful doctor. Please, Tanya, thank you for joining us today, Dr. Tanya Dempsey. We're going to speak about the importance of mast cell activation and ways of treating mast cells in the complicated Lyme patients. So, Tanya, thanks for joining us.
Thank you for having me.
Yeah. So why don't you tell people a little bit about how you got into this? Because every doctor has another story of how they entered the Lyme world. How did you get involved in all of this?
Well, I think I have to thank you. Okay.
Oh, I was somehow responsible for what's going on. Oh,
Oh yeah, yeah. I hold you completely responsible. I was doing I started my career doing internal medicine and then realized, very quickly that, just doing straight medicine without understanding root cause and connections in the body wasn't working. Started my integrative practice, and very early into starting my integrative practice around 2011, I somewhere maybe I think it was like 2012, 2013, I was speaking at a conference that you were speaking at as well. And my first practice was opened in Armonk, New York, which is in Westchester County, which is an endemic region of New York. And I didn't really realize it, which is kind of crazy. So I
mhm.
was seeing patients that are complex. I'm trying to figure them out. And I heard your talk. And what I think is really interesting about it was my mother was at that talk with me. And throughout the entire talk, I don't know if you know the story, but like through the
No,
entire
truthfully, this is the first time I'm hearing it, but I know your Russian mother very well, so I'm really curious to hear the punchline on this one. Yes, go ahead.
so she kept turning to me like after like the first 10 minutes, like she was like, really like totally enamored by your talk. And then all of a sudden she starts turning to me and goes, like making these faces, and I'm thinking like, what is she thinking? And then you're listing all these symptoms, and then at the end she's like, oh my goodness, I think I have Lyme and Babesia. And I looked at her and I thought, yeah, because we had been struggling. She had migraines, we couldn't control them, she had night sweats. But it didn't make sense because she would, already years after menopause, she had these symptoms, and she literally, after your talk, was like, I think I have Lyme. And I was like, oh my gosh, okay. But then how many of my patients really have Lyme? So then I spoke to you briefly, and you asked me about where I was practicing, and I said, oh, Armonk, and you said, oh, you must see a lot of Lyme. And I said, no, I don't think so. And you said, yes, you do. And it was literally like that was on a Sunday, right? I went back to work on Monday, and then my eyes were open. And then it was like, you can't unsee, you can't unsee what you
No,
see.
look, well, you got a taste of the epidemic years ago, and by the way, ultimately, your mom had it, got better.
Yeah. Yeah.
Great,
Much
but
better.
you and I have both been on the front lines of an epidemic now that, in a sense, has been denied for a long period. But you're right. I mean, it was the same thing with me going to Dutchess County. So yeah, so it was kind of like you had that eye-opening experience, and with your parents, right? I mean, it was like, hey, got to get my mom better, right? She helped me to get through med school. I gotta pay her back with her kindness.
How to do it. And I have to say that I did learn on her, that's like the unfortunate thing. But she responded well. I learned, a lot from you, learned a lot from other colleagues. And then, the more patients you see, the more you realize it. And then, somewhere around 2014, 2015, I diagnosed my first patient with mast cell activation syndrome. And then things started to make even more sense.
Mhm.
These patients who have chronic infection, whose immune system is dysregulated. And why are they dysregulated, right? And then you start to understand this piece of the immune system and how it's impacting their ability to get better, how it's affecting the ability to treat them, right? And so then that just opened a whole, host of other
Right.
things. So
Right.
that's
And now, of course, you become, I think, one of the world's experts on mast cell activation with Larry Efford, right? I mean, you guys have one of the largest clinics probably in the world treating these kind of really complex patients. So for people, I think a lot of people out there know about mast cells, but why don't you give people like just a 101, what exactly are mast cells? What are the symptoms they get from it? One of the earliest things I learned was like immediate hypersensitivity to stuff, right? With smelling or touching or tasting. So just give people like a quick overview of the mast cells in the body and the symptoms they would expect everything from sinuses to lungs to GI to heart, just to give people a sense, because people are going to be listening and probably shaking their head going, "Oh yeah, that's me." So go ahead, give them a quick overview.
Okay, mast cell 101. So mast cells are they're white blood cells. They're our front line of defense against the environment, against things that are bad, right? They're protecting us. And they are really strategically placed in our body at all the interfaces with the environment because they're protecting us from the environment. So
Mhm.
you have tons of mast cells on your skin and in your respiratory tract, in your GI tract, all the nervous system, all the places where they have to respond. Okay. And they respond to things that mast cells do for you is that they respond to infection, viruses, parasites, bacteria, fungi. They respond to toxins in the air, different types of pesticides, petrochemicals. So there are lots of things that the mast cells are really, kind of designed to address. And one of the ways they do that, they have a couple of different mechanisms of helping us fight. The first thing they do is they manufacture chemicals. We call them mediators. And these mediators get released from the mast cell. We call it degranulation. They get basically, I think about it as like a mast cell exploding.
Mhm.
And mast cells can make over 1,000 different mediators. Actually, we now know there's something like over 1,200 mediators that mast cells can make. And one of them that a lot of people might have heard of is histamine. Histamine is just one of 1,200 other chemicals that they could make. And when they release these chemicals, the goal is to inactivate, to stop whatever is happening, right? That's one of the ways that they do this. And so, but when they release these chemicals, they're releasing them in the tissue where they're living. Okay. Because again, mast cells are white blood cells, but a lot of white blood cells are in your bloodstream. The mast cells are actually in all your organs and tissue. And so when they release these chemicals, what they do is they actually cause an inflammatory reaction at the site where they are reacting. And then that chemical reaction kind of broadens and can become more systemic because there's a lot of crosstalk in the body and a lot of communication happening. But if the mast cells are responding, let's say, to something let's say you put a cream on you, like some kind of lotion, and you have a reaction to it, they can cause a rash, hives, itching. There are lots of things they can do in the skin. Maybe they're reacting to something in the air. Maybe they're reacting to something that you've eaten. But skin stuff is very common in mast cell patients. Um, Respiratory symptoms, sinus stuff, congestion, asthma or wheezing, cough, in the GI tract, nausea, vomiting, diarrhea, constipation, any kind of inflammatory process in the gut, even like motility issues, gastroparesis, um, in the nervous system, we see because nerves and mast cells talk to each other, so we see mast cells releasing their chemicals, then the nervous system releasing their chemicals. You can see pain, you can see neuropathy, you can see anxiety, depression, OCD, PANS, PANDAS, migraines. The list goes on.
It's pretty much every Lyme symptom that people come in with on a regular basis, mast cells are underlying part of that reaction in, would you say, a large percentage of the people that we're
I
seeing?
would, I
Yeah.
would, I would. And that's exactly right. So I always say that I think the bugs are doing something, but I think the mast cells responding to the bugs are really what's driving the majority of the symptoms.
Right. So,
And
so Lyme and Bartonella will drive it, but you stick mold on top of it, and then that
yeah.
mold is pushing the mast cells even harder with the infections, right? With the Lyme and Bart. And then you get long COVID, and that's pushing the mast cells on top of the mold, on top of right. So, I mean, I think the reason maybe you're seeing so much of this is it's now multiple triggers that maybe we didn't all have years ago, is why we're seeing so much of it.
Oh, absolutely. I like to think about things like in an evolutionary, way, right? And anthropologically. So, if you think about early humans, they were in contact with, yeah, pathogens, definitely, parasites, bacteria. They didn't have antibiotics. They didn't have ways to treat it, right? So mast cells were particularly important at trying to help them, fight those things. There weren't a lot of toxins in the air, right? There weren't a lot of other things that mast cells had to worry about. Nowadays, right, fast forward, and it's the pathogens plus the toxins plus the plastics and the right and the list goes on. So I do think that we are seeing an explosion, and I think it's going to get worse,
Mhm. Yep.
unfortunately.
So, question, do you know whether these microplastic studies that are now coming out, where we're getting like a credit card of plastic every week in our body, is
Oh,
showing up in the arteries, right? It's showing up in the brain, it's showing up in all the organs. Is there evidence that it's one of the things that may be driving? Because all of us are getting it at this point. It's just a question of how much.
yeah. Yeah, we have a group that we collaborate with at UT San Antonio. Dr. Claudia Miller heads that group. They specialize in chemical intolerance and tilt, or toxicant-induced loss of tolerance.
Mhm.
And they've been describing reactions to plastics and petrochemicals and pesticides for years. And when we started collaborating with them, we looked at our data and our practice and correlated with some of the stuff that they do. And what we found was that mast cells were really at the root of chemical intolerance,
Mhm.
and the plastics and chemicals and toxins were the root of that problem. Like they were stimulating mast cell dysfunction, and then sort of setting the stage, right? So I think about these things as like there's a vulnerability that everyone has to some extent, and maybe some people more because there's maybe some genetic factors, and that vulnerability then is sort of hanging around, and then you get a bigger mold exposure, you get Lyme disease, you get right, and then all that vulnerability that maybe was set up by the plastics in the environment and all the other things, then sort of bring those mast cells to a new level of dysfunction.
Right. And by the way, and there's really no organ in the body. I mean, you mentioned the central nervous system, you mentioned the GI tract. By the way, there was a patient, it's not even a patient of mine, it's a friend of my wife's. She's at Baylor in Texas. They're
Mm.
having this workup for unexplained GI symptoms with nausea, vomiting, diarrhea, the most severe pain. They take out her gallbladder, they run every test possible, they can't figure it out. She's a friend of Lee's, and she says, Rich, you have any ideas here? And I said, I will almost bet you bottom to dollar it's going to be mast cell because it's intermittent. It's only happening every few months. I wonder if she's eating certain things, setting it off. So I said, run a tryptase, run a histamine, run a chromogranin A, run a, prostate. It turned out that the tryptase levels were off the wall. She finally got on cromolyn sodium, got off the things that were histamine triggers, and she has not had one episode. And the guys from Baylor are looking at me like, what kind of magician are you diagnosing people from far? But what they're not realizing is you and I, we are seeing these unusual mast cell symptoms in people that anytime you think, what is this unusual symptom due to? Without oversimplifying it, the mast cells are oftentimes involved in these things, even the bladder, right? You're seeing people with IC and bladder symptoms with this too.
Yeah, yeah. Oh, absolutely. Again, like every organ, vaginitis, dyspareunia, again, neuropathy. It's like it just the list goes on. And I do have to be, we have to be careful. We don't want to overdiagnose people, but it's really hard when you start hearing multisystemic, right? So once you start to hear like maybe there are multiple parts of the body involved, once you see some the waxing and waning of the symptoms, once you see inflammation as a hallmark feature, it's kind of hard not to jump to that conclusion.
Right. I mean, we're not saying it's the only form of where the inflammation is happening, but it's one
Right,
of those inflammatory pathways that's playing a big role, and it's quite important. So
right.
tell people briefly, I mentioned them just quickly, and we know there's going to be problems with this because you've taught this to me as far as how fast histamine's in the blood, but just give people the basic blood tests if they were thinking, do
Yeah,
I, as a chronic Lyme patient, maybe have mast cell? I'm immediately hypersensitive with, nasal congestion and wheezing and sneezing and itching and GI symptoms and all of it. What would be the tests that you would start with for these patients to try and make the diagnosis?
yeah. So, and let me just say before I jump to that, that you don't need allergic symptoms. I want to be really clear. You don't need allergic symptoms to have mast cell activation syndrome, right? You can have just the GI, and you can have skin, and you can have other stuff, but you don't necessarily have that, right? So I just want to make a point because I have so many patients who come to me who are told they can't have mast cell activation because they don't have allergy. And so I just want to put that out there. So testing is a little bit complicated for a number of reasons. The mediators that the mast cells produce and release are typically thermolabile, which means that they're sensitive to heat. They're very transient and they dissipate very, very quickly, right? So the collection has to be done correctly. Like we have a special, like we've set up a special lab in our office so that we can collect it properly. And we've partnered with another lab that knows how to process the samples so that we keep the samples cool. We have a refrigerated centrifuge that allows us to process the blood. But you want to see histamine levels in the blood, and it is easier to measure histamine when you can do it with a like we freeze our tubes and we keep them cold, then we put them in the refrigerated centrifuge. It's going to be easier to find, but histamine in the blood, plasma histamine and whole blood histamine can be tested. Tryptase, but I'll talk about tryptase a little bit because tryptase is not a great marker for mast cell activation syndrome for a number of reasons. Chromogranin A, right? So those are like the really easy ones that can be done in the blood. Then the other one in the blood that's not as easy to do, but is the most sensitive marker for mast cell activation syndrome is heparin. Mast cells are the only cell in the body that makes heparin. So it's a very set, like if you have heparin in your blood and you are not taking heparin, which is a blood thinner that people may have heard of. It's often given in the hospital for blood clots. If you're not on that, and there's no reason why you should have it in the blood. The problem with measuring it is most of the tests available are for people who are taking the medication. And so the ranges that they're looking at are much higher, and mast cells make like minuscule amounts. So we found a lab that can measure it really, really like at minuscule amounts. And then that could be, a really great tool because a lot of people don't have histamine, but they have heparin in their blood.
So these are not the classic labs like LabCorp, Quest, BioRef. These are specialized labs that have to do this
Yeah. Well, for heparin,
for heparin, yes.
unfortunately, LabCorp and Quest and those commercial labs, their assay doesn't go low enough to detect.
Mhm.
So what I find is sometimes the hospital labs, that's what we've partnered with, a local hospital, their lab seems to be able to go down low enough to get the heparin. The other stuff though, histamine, chromogranin A, you could try to get it through a regular lab. Sometimes it comes out and that's great if you can.
I would say the most common one I see probably is chromogranin A,
Yeah.
followed by
Yeah.
tryptase. And rarely, I don't even know, I can't remember the last time I've seen a positive histamine. I had one when I checked, but that's before I knew like that the foods I was eating was stimulating so much histamine in the body, right? I mean, I'm off all my asthma sprays and all my stuff since discovering like, oh, Richie has leaky gut. He should not be eating these foods and needs, and then all of a sudden my reactions got much better. And you'd think somebody in medicine, considering how bad asthma's gotten in the world with pollution, you'd think that somebody would have integrated this in medical school training to have people understand how important, food allergies, leaky gut, and mast cell actually is, that it's not all about taking sprays and taking singular help, right? But you got to get to the root causes of why these things are there.
I know. Well, my hope is that the more we do programs like this, the more we educate people in the communities and also hopefully educate other practitioners, right? You hope that eventually it's going to make its way to the med schools where they're going to teach this stuff.
Right.
I'm an optimist there. It's going to happen. It's going to happen in our
But
lifetime.
but regarding these tests, you oftentimes have to do multiple assays to get it, right? You can't always just get it on the first run. If you suspect it, you got to keep doing them.
Got to keep doing it. Yeah,
Yeah,
yeah, exactly.
good.
And then nuances, right? If the chromogranin A is really high, you've got to look for other causes of chromogranin A besides mast cell activation syndrome. If tryptase is high, you've also got to look at other causes of elevated tryptase. So the two things that we see very frequently are, well, not very frequently, but that frequently cause high tryptase is mastocytosis, which is the
Mhm.
cancer of the mast cell, which will cause high tryptase levels, typically over 20. And then people who have that tryptase level that's sort of like between 10 and 20, can have a hereditary genetic condition known as hereditary alpha tryptosemia, which is that they have an extra copy of the gene that codes for that protein, the tryptase, and so they make more. And some of them definitely have symptoms of mast cell activation syndrome, but it's the tryptase doesn't represent the activity of the mast cell; it represents this genetic problem. Okay, so tryptase is a little tricky. Um, and then there are a host of urine tests that can be done, both random and 24-hour, that also have to be collected very carefully. It has to be remain cold, has to be brought to the lab cold. The lab has to pick up cold, keep it cold, study it cold, because otherwise these mediators dissipate. And so it could be uh, the metabolites of histamine, like N-methylhistamine, leukotrienes, prostaglandins, different types of prostaglandins, prostaglandin B2, 2,3-diner F2 alpha, prostaglandin F2 alpha. So there are a bunch of them that we can measure in the urine. And I would say out of the ones that I do in the urine, leukotriene is the one that I probably see the most when we catch it. And then lastly, you can diagnose mast cell activation syndrome also through biopsy samples. So, a lot of our patients have had colonoscopies, endoscopies. They've had tissue, checked, especially because a lot of our patients have GI symptoms. And you can request blocks of unstained tissue. And if you have a pathologist that you can find, we have a pathologist that we work with that we send our blocks to when we request them for patients. And she will run a CD117 stain on them. And the CD117 stain specifically stains for mast cells. And if you see a slightly higher number in the GI tract, we say over 20 is usually indicative of mast cell activation syndrome.
Right. So if people have already had biopsies for colonoscopies and the rest, they save these, that sometimes it can go to a pathologist or it's too late by that time.
Correct. So they save them sometimes for 5 to 7 years.
Okay.
So people can request and then send. Sometimes the actual lab that did it will be willing to restain them. Sometimes they're not because they don't believe this. They don't feel like they're comfortable doing it. They've never done it. And so, we'll again, it's always easier to work with a pathologist, we know. And what you want for diagnosis is you want 2 points of laboratory evidence in support of uh, dysfunctional activated mast cell. So a mediator and a positive biopsy, or 2 mediators that are positive, or at least like histamine or chromogranin A, or twice if that's the only thing you can get. We wrote a paper in, I think it was 2020, that talks about the diagnostic criteria. We call our diagnostic criteria consensus 2 criteria. And so that's what we use. We say we can use tryptase, but you don't have to rely on tryptase. And we go through all these different things if people want to read.
Okay.
Open
Great.
access.
So what do people, so obviously you've got to get to the sources of it. Do you find like once the Lyme is properly treated, the BART is treated, the mold is pulled, you've treated long COVID, do you find at that point when the triggers are no longer there, and we'll talk about medications and supplements and things we use, do you find then the mast cell activation is better once the actual triggers that are triggering the mast cells are better?
That's an excellent question. And I would say it's complicated.
Hmm.
So there's a subset of people who have what we'll call secondary mast cell activation syndrome. And secondary mast cell activation syndrome is basically that they have normal mast cells at baseline. They get Lyme disease. Okay, but their immune system was normal before. They
Okay.
get Lyme disease, you treat the Lyme, or the mold, or whatever it is. And when you remove that trigger, their normal mast cells return to normal and their symptoms return to normal, and they're essentially, quote unquote, cured, right? They're in good shape. I think that's very rare, and I've almost never seen that. What's more common is, but I've definitely seen it a few times, but what's more common is, what we'll call idiopathic mast cell activation syndrome. And in the majority of cases, that's sort of like it's a combination of like a primary and secondary. So they have dysfunctional mast cells at baseline. Okay, so what I think happens is that people are exposed to things very early on in life. Some of it is because of like genetic vulnerability, and then they're exposed to various infections, they're exposed to stressors. Parents got a divorce, there was a death in the family, there was abuse, there's trauma. I mean, they live on a farm with pesticide, or there's um, maybe a farm nearby. I mean, there's so many factors, okay? But I think that there's early in life exposures or triggers that sort of bring out the dysfunctional mast cells. And so at baseline, their mast cells are sort of like leaky. You mentioned leaky gut. I think about it as leaky mast cells.
Mhm.
They're leaking a little histamine, they're leaking a little bit of mediators, they're causing low-level inflammation. These patients may realize that they're not, healthy, or they could think they're very healthy. They may not even realize it. They may say, oh yeah, I have seasonal allergies. Oh yeah, I get migraines once in a while, but I'm fine. I'm healthy. I work out, I do this, that, and they really do seem fine, but their mast cells are really not. Then they get a mold exposure and or, Lyme, Bartonella, whatever. Now their dysfunctional mast cells are brought to a new level of activity. You treat that. You take that all away. You take all the triggers away. Now their mast cells can calm down, but they're now going to return to they're never going to return to normal because they weren't normal. They were always dysfunctional. So now they're going to return to a better dysfunctional level, not as reactive, and they may be quieter, but a lot of these patients will still require some treatment or some vigilance, that the mast cells can get activated pretty quickly, because they may just be quiet for a little bit, but then there's a trigger that comes along, and because they weren't fully normal, they get reactivated. Does that make
So, so
sense?
these are the people that may have to stay on H1H2 blockers and montelukast and or cromolyn sodium. Like they have to stay on the
Allopurinol.
stuff longer term because they have these dysfunctional mast cells even when the triggers have been removed at that point.
Correct. Correct.
Great.
And I think people don't want to hear that. They want to hear that they can go off of everything. And so I definitely do trials with patients where we say, okay, let's try to wean you off and see what happens, right? And if they start to wean and they flare, we have our answer, and if they wean and they do well for a period of time, great. And if the symptoms come back, then it's a sign, all right, you got to get back on the stuff. So, you can experiment, but I would say, again, vast majority are going to need long-term treatment at some point in their life.
Got it. So now that we've done and that was, by the way, a great overview of the biochemistry 101 on mast cells. So now let's do treatment 101
Okay.
about how you layer it up for the more complicated patients. So where do you start with these patients with mast cell?
So, again, it depends, right? I have pharmacologic tools and I have non-pharmacologic tools. Now, some patients I might start non-pharmacologic. It really depends. Some patients are very fearful of drugs, right? So I might start, with a quercetin or vitamin C or NAC or ALA or something. So those are all theoretically mast cell stabilizers or antihistamines. Um, I might start with a pharmacologic H1 blocker, histamine blocker. That would be the class of antihistamines, Claritin, Zyrtec, Zyzal, Allegra, Benadryl. There's some that are prescription. Those are all over the counter. So we kind of start there. And I will say that, beyond stuff that I want them to take, a real key piece, I know you're going to agree with this, a real key piece is limbic retraining. So while we're treating them, with stuff to calm down the mast cells, we see the role of the nervous system and the autonomic nervous system and the limbic system. And I think that a lot of people should be doing limbic retraining either at the same time. You,
I know.
you.
Look, I know I need to do it. I walk down the hall. My wife says, I don't feel like cooking tonight. Let's go get a pizza. Almost immediately, I'll start sneezing, right? Just with the idea of eating a pizza, even though, by the way, my tolerance for dairy has gotten much better over time. Oh, I recognize for myself, I need to do Olympic training to reverse because I've got it wired in because I had allergies, severe allergies. And again, you said it's not always mast cell, but my whole family, I remember my father and my grandfather during, spring season, literally like waterfalls flowing from their nose and their eyes. Their allergies were so bad, and I inherited, some of that. So I agree with you 100% on the limbic, and I more and more over time, and I've been speaking to doctors during this doctor talk about it. I think everyone now is starting to realize that the limbic retraining is an essential piece of the healing from Lyme. Whether you think you've had trauma when you were young or didn't, there's certain things that have just gotten, they just need rewiring. And you're now saying, hey, the mast cells is part of that.
Yeah, yeah, absolutely. And I see some incredible results. Sometimes it's the key to unlocking this whole thing. And sometimes it's just a piece of the puzzle that they need in order for other things to work.
Yes.
Sometimes they're so reactive that, we can't start with limbic retraining. We got to calm things down first, then enter the, limbic retraining. But I want to mention that because I think that's a really key component, to talk about. There are really like, at least 30 different drugs, if not more, that we can use for mast cell activation syndrome. There are lots of different supplements that are being looked at, things like Akkermansia, things like different probiotics, again, different kinds of anti-inflammatory compounds can have some, the COX, if they have some COX activity, COX-1 or 2, they can help to reduce inflammation. We have those on the pharmacologic side. We have it on the non-pharmacologic side. So it really, I think that what's helpful about doing the testing is that sometimes if you know what the mediators are, you can target things a little better, right? So if a person like you has a lot of histamine, right? A lot of the things that we're going to be gearing towards is going to be against the histamine. We're also going to look at other stabilizers and things like that to calm the mast cell down. But I know histamine is your issue, right?
Right.
There are other people who I can test histamine, 20 times. Histamine's never, it's not their issue.
Mhm.
Maybe their issue is leukotriene, right? So then I know that I need like a Singulair or an Accolade, or I need something in that. Sometimes even like the SPMs, the pro-resolving mediators can help with the leukotrienes. If I know there's a prostaglandin D2 issue, then I know that like all the COX inhibitors and things like that will target the prostaglandins. So sometimes it's not perfect, but sometimes you can gear it towards what the mediators are. And sometimes a lot of it is just trial and error. And you've
Yeah.
got to give like 2 to 4 weeks with each attempt,
You
unfortunately.
normally use, for example, something like famotidine, an H1 and an H2. Do you find that blocking histamine 1 and histamine 2 is just part of your general protocols that you find, helpful?
Yeah, and listen, there are a lot of patients who do better. It's interesting. They do better with H2 than H1, or they do better with H1 versus H2. So I can't use them together in a subset of patients. And
Mhm.
some, it's very clear. You put them together, and the more histamine receptors that you can block, because the mast cells themselves have histamine receptors. So when you use these histamine blockers, you're blocking receptors on other cells and you're blocking the effects of histamine, but you're also feeding back on the mast cell and telling the mast cell, hey, stop producing all this histamine. So by blocking more histamine receptors with H1 and H2, you might achieve that a little better. It's unfortunate that we're limited with the number of H2 blockers that we have available these days. Zantac was like a game changer for so many patients, ranitidine, but it was pulled off the market because of a chemical that they found that was produced in the manufacturing process. I keep hearing about it coming back, and I'm still not able to find it.
So you
Um,
you actually found ranitidine was better than famotidine when you were using it as far as an H2. That's interesting.
yeah, for subset of
Yes.
patients. For other
And
patients,
what about I mean, cimetidine is still around. I use it in the dapsone protocol, as you
right?
know, to lower methemoglobin, and even these even have antiviral effects. Do you find the cimetidine has?
Yeah. for some people,
Some
cimetidine is the answer. But you know that cimetidine does have some interactions with some
people,
drugs,
yes.
a little more challenging. But at least we have that, right? So we have the famotidine, we have the cimetidine. We used to have a prescription one called nizatidine. I think that
Mhm.
was also pulled because of the same issue
That
with
was from years ago. You're bringing me back to years ago. That's correct.
Axid. Remember Axid? I think that's what it
I
was
do
called.
remember it well. Yes. Yeah.
So,
So for a lot of people, it is going to be a little bit of experimentation. But what you're saying is if you can get the mediators, if you can show which mediators there, you can be a little bit more specific with the targeting. But there will be some people that need an H1, H2, like, using something like Zyrtec and Pepsid, using Montelukast. When do you decide to use the cromolyn sodium? When are you using that for the gut?
so, you know, typically I like to start with H1 and H2s because they can be so profound, right? But sometimes either they're not enough. So maybe in some patients, they're noticing that it's helping some symptoms, but it's not really helping other symptoms, or it's not helping at all. And then I'll move on. Cromolyn might be the next thing I try. Ketotifen may be the next thing I try. It really depends. Certainly with gut symptoms, I might, gravitate towards the cromolyn. The other symptom that has me gravitating towards cromolyn lately is neurologic symptoms. What's fascinating about cromolyn is that it's a drug that does not get absorbed.
Hmm.
It comes in a liquid. If it's compounded, it comes in a powder capsule. You take it, it works in the gut, calms down mast cells in the gut. Now, there are going to definitely be people where their mast cells do not like cromolyn and makes their GI symptoms worse. But there are going to be people who do not have GI symptoms, but have a lot of neurologic symptoms. Could be anxiety, could be OCD. I've seen this I have a couple of pandas cases. For whatever reason, it's like a crosstalk between the mast cells in the gut and the mast cells in the nervous system. And we know that there's so much of the nervous system in the gut, right? And probably that nervous system is talking to the rest of the nervous system. And so they take cromolyn and like their anxiety disappears or their OCD.
Wow.
Yeah, it's pretty
Oh,
mind blowing.
that's fast. That is absolutely fast. This is the first time, by the way, I've heard this because,
Really.
we've interviewed people before regarding Pans Pandas and using IVIG and all the things they're doing. This is the first time I've heard anyone. That's a fascinating, trick to know that the crosstalk between the gut and the neurosystem, you're seeing that. I've never heard that before. Now, by the way, that should be published. I don't know if you've got even a case study on it.
I do.
I
Okay,
don't
it's
want to
on
give
my
you more
list.
work, but it sounds like that's actually a case study that you may want to consider publishing.
Yeah, yeah, no, 100%. Yeah, I have a list of cases that need to be published. But I've seen again and again, not just cromolyn, but other mast cell targeted therapy helping inflammation in the brain, autoimmune encephalopathy, helping neuropathies, helping anxiety, helping some of these other symptoms, even depression. So we know that the mast cells are playing a huge role. And if you could find the key to those mast cells, and again, sometimes it's cromolyn, but sometimes it's other things, then if you can, figure that out, then like everything just sort of, gets better. So it's pretty
No,
interesting.
that's a great point with it. So obviously it is going to be individualized for many people. I mean I found in general, I don't do specifically, obviously not as much as you do, but I do find that I have a lot of patients that are on H1, H2 blockers with Montelukast. Some of them are taking chromium. They're using like Histoquel from Research Nutritionals with quercetin. They're on vitamin C. Histeo using again the
Yeah,
diamine oxidase. This is mostly going to be in the people that are releasing a lot of with histamine symptoms. Otherwise, you're not going to find it to be all that helpful, correct?
correct. And histamine symptoms that tend to be more in the gut or related to the food intake, right? There's some very specific things that I think His-DAO can help with. I had a case, okay, another case that probably should be published. I had a case of a patient who actually did not have GI symptoms, but this was very, very, very early on in my mast cell journey, right? So this could have been 2014, 15. She wasn't the first patient, but she was a patient that was mine that I had as a primary care patient for a long time. And once started diagnosing other people, I was like, the light bulb went off and I was like, wait a second, I think that's what you have. She had interstitial cystitis, fibromyalgia, and migraine, I think were her main symptoms. And I started treating her, H1, H2, took a while to figure out she could only respond to a very specific formulation of Claritin. It couldn't be Claritin brand. It had to be like Rite Aid brand. It had because excipients can be an issue. So we had to find one that had, specifically she figured out which brand was best for her. We did all that. And then again, early on, I didn't know all the tools. So Histia we had access to. So I started her on that and it helped her IC. It helped her interstitial cystitis because
Yes.
clearly histamine was part of her thing, right? And again, at that time we were having trouble testing. So I just made assumptions. And so there was a case of Histia for a non-gut, result. So
Yeah. And when do you decide to use ketotifen? Is it mostly just in these people that just have severe symptoms that are failing the classical therapies? When do you add it on for these people?
yeah, it doesn't have to be severe symptoms. I mean, any symptom that is not responding to like the first line H1, H2s, I think you can go to ketotifen. I kind of think about it this way, like it could be ketotifen, it could be cromolyn, it could be low dose naltrexone. That may be my next level. And again, depending on symptoms, depending on their response to other things, I might go the ketotifen route. So ketotifen has some antihistamine properties and is a mast cell stabilizer. So I might think, like, let's say they're getting response to an antihistamine, and we've tried all the antihistamines. We figured out, all right, loratadine is the thing that works for them, but maybe it's only helping like 60% of the time. So then ketotifen might be worth it because, maybe I get a little more antihistamine property, but then I also have the stabilizing property, right? And we see what
Mhm.
happens. Um, the reality is that until we have studies that allow us to look at the genetics of a patient's mast cells to know what mediators they're really making, because I think if we could do that, if we can map out the genetics of the mast cell, because there's
Mhm.
somatic mutations that are different in different individuals. So if you knew that, their mast cells were making certain things, you could probably figure out, okay, they're going to need ketotifen, they're going to need montelukast acid. So we're
And even though they're a good genomics lab, like Bob Miller's nutrigenomics lab, I mean, they still won't do those kind of testing that you're talking about.
no, because those are like that's the genome, that's the um yeah, how do I distinguish it? I'm talking about mutations at the level of the mast cell. We call them somatic mutations, which is not the systemic, your genetic.
And you mentioned LDN, and of course, we use a lot of it in our Lyme patients to decrease microglial activation.
Yeah.
So, is it the LDN is also decreasing some of the mast cell activation that's going on in the brain? Is that exactly what's happening with some of that?
And yeah, naltrexone is binding the mast cell. Mast cells have opioid receptors also. And so I think it's directly addressing and stabilizing mast cells, not just in the brain, but also elsewhere in the body. It's modulating the immune system as a whole. And so in some patients, that's helpful. I certainly have patients that don't tolerate LDN for a number of reasons. I still can't figure out how we figure out who's the person who's not going to tolerate it. But when it works, yeah, it's pretty, it's also pretty remarkable.
Yeah. No, that's great. Tanya, I knew we'd run almost an hour. So we're almost an hour. So why don't you just tell people, first of all, how do they get in touch with you? Because I know a lot of people are going to access your wisdom here. What's the best way to get in touch with you?
So, okay, so I have a website, drtanyadempsey.com. And I have a lot of blogs and a lot of resources for patients with complex chronic diseases. I have MCAS guides. I have lots of things on my website. I have social media, Instagram, Dr. Tanya Dempsey, MD, Facebook, Dr. Tanya Dempsey. I have a podcast called Mast Cell Matters, which I'm really proud of, and we've had some really great interviews and I don't, have we interviewed you yet?
I'm not yet.
Okay, well, that's you're definitely going to be on. Um, and so we're just starting, so yeah, you're definitely going to be our guest. But we interview everything sort of mast cell related and also mast cell adjacent. So the other complex illnesses that overlap, such as vector-borne infections, of course. Yeah, so those are the best ways to sort of see what I'm doing and reach out, and always happy to hear from people.
Good. Well, thank you, Tanya. This was great. I know people are going to get a lot out of this because it turns out the mast cells is really an important piece of all of these people that we're dealing with chronic Lyme and co-infections. So thank you for taking the time today to share. By the way, any other pearls, any other thing we didn't cover today that you think people might want to know about?
Yeah, I mean, I think one thing I would say is that this is fairly common, mast cell activation syndrome. Some studies have shown that at least 17% of the population, I think it's closer to 20% now, have it, right? 1 in 5 people. So very common. I think it's probably going to get a little worse. So you're not alone. People listening to this who are thinking, wow, that's me, and they feel isolated. They feel like no one, believes them. They think, that everyone sort of thinks they're crazy because the symptoms are coming and going and moving and migrating. And what I want to say is I think there are a lot of people out there who have this, who don't even realize they have it or are suffering silently. So you're not alone. And thankfully, there are programs like this, again, podcasts and other educational tools. And so, empower yourself, teacher practitioners and doctors, if they don't know about it, help them help you get better, and that's sometimes,
No,
unfortunately,
thank
what's
you.
needed. Yeah.
Because inflammation is the underlying cause of all the symptoms people are getting with chronic Lyme and most of these diseases. But I think the mast cell piece is an important piece of that inflammatory response, as you explained. I mean, it's on the skin, it's on the interact, where the GI tract is. So, I mean, it's everywhere in every organ in the body. So, considering, I mean, look, I didn't know about it years ago when I was dealing with more allergies and asthma. Ever since I started using some of these things and getting off my histamine foods, my health has become much better. So I think it's a real turnaround for people and there's hope. And I think it's another piece of the puzzle, right, that really helps people with chronic Lyme disease get better. So thank you for taking the time and sharing. That was great. So for everyone who's been listening, you've been listening to Dr. Tanya Dempsey, one of the world's experts on mast cell disorder. You can find her in. So now you're not in Armonk now. You're located where exactly?
Okay, I'm in Purchase, New York, Ames Center for Personalized Medicine
There we are. Okay.
in Westchester County.
Very good. So thank you again. So again, this has been Dr. Richard Horowitz. I'm the co-host of the Dr. Talk Healing Lyme Summit 2.0. Thank you for joining us today. We hope to see you again for another episode soon. Thank you.